Hello all, welcome back to the series of lectures on internal medicine. This is Dr. Maithreyi. Today we will be discussing a very important topic, that is cardiomyopathies. Okay, so let's begin. So what exactly are these cardiomyopathies? So cardiomyopathies, as the name suggests, are a group of disorders that affect the myocardium. Okay, so why are these group of disorders classified separately, right? So the two important points that you have to remember is that this is a group of disorders affecting the myocardium in the absence of ischemic heart disease and in the absence of valvular heart disease. Okay, so these are disorders which are primary disorders of the myocardium. So even ischemic heart disease and valvular heart disease or even hypertensive heart disease can cause heart failure. But once you rule out this IHD or valvular heart disease and hypertension or any other secondary forms which affect the myocardium, then this group of primary disorders are what are called as the cardiomyopathies. Alright, so how do we classify these cardiomyopathies? Now let us just look at the schematic diagram. So the first type of cardiomyopathies is the dilated cardiomyopathy. So you can see that all the chambers here are dilated. The RA, the RV, the LA and the LV are dilated. So this form of cardiomyopathy is called as dilated cardiomyopathy. The second type of cardiomyopathy is called as your restrictive cardiomyopathy. Okay, so this is called as your restrictive cardiomyopathy. What is the restriction here? There is stiffening or thickening of the ventricles and the ventricles become non-compliant, right? So the ventricles become non-compliant and there is a restriction to filling of blood when the blood flows from the atrium to the ventricle. So as a result of this, there is a pressure overload in the ventricles and the pressure overload in the atria and the atria become dilated. So this form of cardiomyopathy is called as the restrictive cardiomyopathy. Then we have the hypertrophic cardiomyopathy, right? So we have the hypertrophic cardiomyopathy. In this hypertrophic cardiomyopathy, there is an asymmetrical septal hypertrophy. Asymmetrical septal hypertrophy. So this form of cardiomyopathy, which is a primary disorder of the myocardium, is hypertrophic cardiomyopathy. Apart from this, we have certain other forms of cardiomyopathy which you should be aware of. One is tachycardia-induced cardiomyopathy. So, chronic or long-term tachycardia due to multiple reasons. Maybe multiple ectopics are there, maybe there is a multiple groups of ventricular tachycardias which are happening, or long-term heart failure in itself as a compensatory mechanism can have tachycardia. That is the reason why we give beta blockers in the treatment of heart failure as well. Because if there is tachycardia, it can worsen the functioning of the myocardium. So that is your tachycardia-induced myopathy. Secondly, we have the peripartum cardiomyopathy. Okay, so we have the peripartum cardiomyopathy. So in this group of disorder, in a peripartum lady, they can develop cardiomyopathy. The third type is your Takotsubo cardiomyopathy. Okay, which is your Takotsubo cardiomyopathy. So this particular disease is a very interesting disease. So this is seen in postmenopausal women. It is seen in postmenopausal women. So what do you see here? What does this word Takotsubo mean? So it was found first in Japan. So in Japan, there is this culture of catching octopus. There is this culture of catching octopus and the pot or the instrument that they use is what is called as the Takotsubo. So in this type of cardiomyopathy, there is a apical ballooning of the heart and which resembles the pot which was used to catch octopus. So that is why it derived this name. So there is apical ballooning. So what is the reason for this apical ballooning here is that in certain individuals, especially in postmenopausal women, when there is excessive sympathetic activity and when there is excessive sympathetic activity. So under stress, typically emotional stress, there is a sudden onset of chest pain, followed by this apical ballooning. Okay, so how does the patient present? The patient presents with history of this typical emotional stress followed by sudden onset chest pain, and it definitely mimics an myocardial infarction, right? So the ECG also shows evidence of a STEMI, or the ECG also shows the presence of ST segment elevations. So many a time Takotsubo cardiomyopathy is misdiagnosed as an MI and it is taken up for a cardiac angiogram. So it's only on the angiogram, that you see this apical ballooning, and there is no block, there is no evidence of any block on the angiogram. So that is the only way that you diagnose this apical ballooning or this Takotsubo cardiomyopathy. What is the treatment? The treatment is basically giving anxiolytics, because this is mediated by sympathetic overactivity, and you can give beta blockers as well. Alright, so this is the special form of cardiomyopathy, which is the Takotsubo cardiomyopathy. Now we will be looking at the various etiologies for the various types of cardiomyopathies. So the first type of cardiomyopathy that we will be looking at is the dilated cardiomyopathy. So let us look at the various etiologies of dilated cardiomyopathy. So the most important is that infections which basically cause myocarditis. Just like how we had learned pericarditis, myocarditis is basically inflammation of the myocardium. Myocarditis basically refers to the inflammation of the myocardium. So this can be associated with any infection, most commonly viral infections. Which are the viruses which can cause myocarditis? Coxsackie, adeno, HIV and hepatitis C viruses. But very commonly that we see in clinical practice is your dengue fever as well. Dengue or the viral hemorrhagic fevers. So these also can essentially cause myocarditis. So myocarditis most of the time remains self-limited, okay? But sometimes in some patients the myocarditis can go on subclinically for a longer time and they present to you at a later date in the form of dilated cardiomyopathy. Alright? So viral myocarditis sequelae is one of the most common causes for dilated cardiomyopathy. Apart from this, you have parasitic infections, bacterial, spirochete infections, rickettsial, fungal infections. So any of these infections can cause dilated cardiomyopathy in the long term. Okay. Let us look at non-infective causes. So matters inflammatory diseases, especially sarcoidosis. So you would have all known that sarcoidosis is an infiltrative disorder. So sarcoidosis generally causes restrictive cardiomyopathy is the opinion that most of us have, but the most common cardiac manifestation of sarcoidosis is actually a DCM or a dilated cardiomyopathy. Alright, then we have the giant cell myocarditis, which is a type of autoimmune myocarditis which is very responsive to steroids. How is this giant cell myocarditis diagnosed? It's diagnosed with the help of a endomyocardial biopsy. Okay. Then we have eosinophilic myocarditis, which is commonly seen associated with hypereosinophilic syndromes. You would have learnt of hypereosinophilic syndromes in the chapter of eosinophilic lung diseases, right? So this is a multi-system inflammatory disorder which is characterized by peripheral eosinophilia with eosinophil counts more than 1500, and the eosinophils infiltrate literally every organ of the body, including the myocardium. So this is your eosinophilic myocarditis. Apart from this, the other connective tissue disorders can include polymyositis, dermatomyositis and an important therapy related is your checkpoint inhibitor related therapy. Let us look at some of the toxins which cause dilated cardiomyopathy. Very, very important is alcohol. Apart from that, catecholamines, cocaine, right? So many a times you would have seen that cocaine, the patients who abuse cocaine can actually present similar to an MI. Chemotherapeutic agents, so very, very important are the anthracyclines and trastuzumab. Anthracyclines cause irreversible toxicity. Anthracycline causes irreversible toxicity. Many of the cancer chemotherapeutic agents, especially anthracyclines, cause irreversible toxicity, whereas trastuzumab can cause reversible toxicity. Okay. The other drugs which are associated includes chloroquine, heavy metals like lead and mercury, and sometimes even occupational exposure. When it comes to metabolic causes, nutritional deficiency, we know that thiamine causes beriberi, which is a cause of high output cardiac failure. Selenium causes something known as K-Shan's disease. Selenium deficiency causes something known as K-Shan's disease. Apart from that, electrolyte deficiencies and endocrinopathies, thyroid disease, pheochromocytoma, and obesity as well. Another infiltrative disorder that you should remember is hemochromatosis. Again, hemochromatosis is associated with restrictive cardiomyopathy, but you can find it associated with DCM as well. Alright, let us look at another group of etiologies of DCM. Always remember that muscular dystrophies, because the muscle protein which is there in the other muscles can also be found in the cardiac myocytes. Ultimately, the myocardium is also a muscle. So, certain inherited genetic conditions which cause muscular dystrophies can cause skeletal as well as cardiac myopathy, especially, for example, dystrophin related, which includes the Duchenne and the Becker's muscular dystrophy. Apart from that, there are certain idiopathic causes of dilated cardiomyopathy, like your arrhythmogenic right ventricular dysplasia, which is your ARVC, and your left ventricular non-compaction syndromes. These are basically developmental disorders. For example, in ARVC, the right ventricle is not well developed. In your left ventricular non-compaction, there is a problem with the left ventricle. Then we have the peripartum cardiomyopathy, tachycardia-related cardiomyopathies. So these are some of the miscellaneous and idiopathic causes of dilated cardiomyopathy. Okay. So we have looked at all the various etiologies of DCM. Now let us look at the pathophysiology of DCM. So what exactly determines the pathophysiology of DCM? So the most common trigger, as I told you, is the infection. Once there is an infection, especially the virus or a bacterial infection, it causes myocyte lysis. So the cardiac myocytes begin to break down and it causes myocyte death. So this will be the first portion or one of the reasons behind the pathophysiology of DCM. At the same time, whenever there is an infection and there is myocyte destruction that is happening, the immune response will be activated. So the T cells and the macrophages are also activated. The T cells and the macrophages basically aim at removing the offending agent or removing the trigger for the DCM. But at the same time, they also produce anti-myocyte antibodies. These are the anti-myocyte antibodies. So what happens if the anti-myocyte antibodies are produced inadvertently? They cause myocyte lysis as well. So finally, this results in your dilated cardiomyopathy. Okay. So the infection causes myocyte lysis. This triggers the immune response. The immune response mainly aims at fighting the infection. However, as a consequence of that, there is also production of anti-myocyte antibodies and myocyte death. So in total, over the course of time, this results in dilated cardiomyopathy. Okay. Now let us look at the clinical features of DCM. So a dilated cardiomyopathy, when all the chambers are dilated, the heart does not function well. So if this is a normal contraction of the heart becomes globular, all the chambers become dilated and they contract very minimally. Okay. So what happens when the contraction is low? There is decreased cardiac output. So, decreased cardiac output basically means there is systolic heart failure. Alright, so there is decreased cardiac output, there is decreased perfusion. So, the patient can present with fatigue. Okay, so the patient can present with fatigue. Diastolic heart failure. So, what happens in diastolic heart failure is that this DCM basically results in a non-contractile heart or very poor contractility. So, when there is very poor contractility, what happens to the pressure in the left atrium? The left atrial pressures increase, and this in turn results in an increased pulmonary capillary wedge pressure, which in turn can cause right heart failure as well. Now, what happens in right heart failure? Because of the back pressures, there can be pedal edema, there can be elevated JVP, there can be hepatomegaly, and there can be ascites. Finally, they can have anasarca as well. Okay, because of the backward failure and right ventricular failure, they can have all of these manifestations. Alright, what are the complications? In a dilated cardiomyopathy, all the chambers are dilated. So, what happens is that the atria are dilated. So, this results in the electrical instability. So, if there is electrical instability because of myocyte stretching, it predisposes to arrhythmias. And arrhythmias, what happens? Especially atrial fibrillation. Atrial fibrillation can result in the formation of clots. What is the most common site of a clot in atrial fibrillation? It is usually the left atrial appendage. Now, why is there a clot? A clot happens mainly because of the stasis of blood, right? So, the heart is not contracting well, and because of the stasis of blood, it predisposes to the formation of clot. Apart from that, they can also have clots in the LV. Okay, so they predispose to arrhythmias, they predispose to the formation of clots. The clot can cause embolism. If the clot causes an embolism, they can have a TIA, they can have a stroke. Okay, so the second complication, if the cardiac output is very low, they have a risk of sudden cardiac death. So, if the cardiac output is very low, they have a risk of sudden cardiac death as well. Alright, so that is about the clinical features and the complications of dilated cardiomyopathy. Now, let us look at the investigations. The first investigation is your ECG. So, what are you finding in this particular ECG? You are saying that there are low voltage complexes in the limb leads, and there are high voltage complexes in the chest leads with a poor R wave progression. Okay, so there are low voltage complexes in the limb leads and high voltage complexes in the chest leads with a poor R wave progression, and this typical ECG finding is called as the Goldberger's ECG triad. This typical ECG finding is called as the Goldberger's ECG triad. Okay, so this is the typical ECG finding of dilated cardiomyopathy. Let us look at the echo. So, the echo, you can see that there is a globular heart. And all the chambers are dilated. Okay, and this is a relatively non-contractile or a minimally contractile heart. Fine. Now, what is the next investigation that you want to do? So, the new investigation which is in vogue is the cardiac MRI. Now, when I had explained to you the definition of cardiomyopathy, we had discussed that these are a group of disorders which affect the myocardium in the absence of an ischemic or a valvular heart disease, right? So, when you do an echo, you know that there is a DCM. Of course, you can rule out whether there is a valvular heart disease, you can rule out if there is a hypertension or a hypertensive heart disease by when you check your BP, etc. But how do you rule out if this is an ischemic heart disease or not? So to find out if this is an ischemic heart disease which is causing a DCM, you have to do an angiogram, correct? You have to do an angiogram and see if there is any block in any of the coronary arteries. But that is a highly invasive procedure and not all patients will be compliant for an angiogram. So nowadays what is in vogue is the use of a cardiac MRI. So this is a non-invasive method. This is a non-invasive method which is used to find out the etiology of DCM. Now how do we use the cardiac MRI to find out the etiology of DCM? This depends upon the pattern. This depends upon the pattern of LGE. What is LGE? It is the late gadolinium enhancement. Okay, so you do a late gadolinium enhancement sequence and you find out the pattern of the cardiac involvement, and using this you can find out whether this is an ischemic etiology or a non-ischemic etiology. You have understood, right? What is ischemic, what is non-ischemic. So if you have this pattern, what is this pattern? This is your transmural pattern. So you have your transmural or your subendocardial, right? Transmural or subendocardial pattern of late gadolinium enhancement. It is suggestive of an ischemic etiology. So if you have a transmural or a subendocardial pattern, it is suggestive of a ischemic etiology. Okay. Now, if you find in the other forms, you have a mid-wall enhancement. You see a mid-wall enhancement or you see a subepicardial enhancement. Mid-wall or subepicardial enhancement. What is this suggestive of? This can be due to sarcoidosis. This can be due to Chagas disease. Or it can be due to any form of myocarditis. Okay. So, mid-wall and subepicardial involvement is suggestive of sarcoidosis, Chagas disease and myocarditis. Now, if you have a global involvement, a global pattern of late gadolinium enhancement, this is seen in amyloidosis. Okay, so this is seen in amyloidosis. So, this is how you use cardiac MRI to find out the etiology of DCM. Alright? Fine. Now, let us move on to the treatment of dilated cardiomyopathy. So, what do you do in the treatment of cardiomyopathy? So, in DCM, in essential, you basically alleviate the symptoms of heart failure. So, in DCM, you alleviate the symptoms of heart failure. So, if the patient is presenting with pedal edema, orthopnea, dyspnea, mainly because of your low cardiac output as well as your backward pressure. So, in those cases, you can give a diuretic. If there is a lot of fluid overload, then you give diuretics. Okay, fine. Then, you give treatment for your guideline directed medical management for heart failure. GDMT refers to the guideline directed medical management for heart failure. So, you can understand this further in our chapter and discussion on heart failure. But as of now, briefly, let us just go through it. So, we have to give 4 major drugs in the management of heart failure. First is your beta blockers. Why? Because in the pathophysiology of heart failure, even including DCM, there is sympathetic overactivity and tachycardia as an initial compensation for the low cardiac output. Now, we have already learned that tachycardia itself can worsen the heart failure. So, we give beta blockers to block this sympathetic activity and decrease the tachycardia. Okay. The second group of drugs which basically help in cardiac remodeling. They basically help in cardiac remodeling and they also help in reducing the afterload, and they also inhibit this overall pathophysiological process is the ACE and ARBs. The ACE inhibitors and ARBs. which is nothing but the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers. Okay, how do they work? We will be looking in the chapter of heart failure under the pathophysiology section. The third group of drugs which we are now using is the mineralocorticoid receptor antagonist. The mineralocorticoid receptor antagonist such as spironolactone. Okay, such as spironolactone. And the fourth group of drugs which we are using is the SGLT2 inhibitors. SGLT2 inhibitors which include your dapagliflozins and your empagliflozin. So we have your dapagliflozin, empagliflozin, which are group of drugs which inhibit the SGLT2. The mechanism of these drugs again we will be learning in the management of heart failure. So just remember that the management of DCM is very similar to the management of heart failure itself. Okay. But if you find an etiology, which can be treated, then you have to treat the underlying etiology for DCM. Okay. So that is about dilated cardiomyopathy for you. So what all have we learned? We have learned about the etiology. We have learned about the pathophysiology of DCM. We have looked at the clinical features about the systolic and diastolic heart failure. And we have looked at the complications. How do you diagnose? And what is the role of cardiac MRI and how do you treat your dilated cardiomyopathies. Okay, now let us look into the next group of disorders, which is your restrictive cardiomyopathies. So restrictive cardiomyopathy, as I had mentioned before, these are the group of disorders which are characterized by infiltration into the ventricles. So when there is an infiltration into the ventricles become very stiff and non-compliant. So there are elevated filling pressures and this in turn causes symptoms similar to the right heart failure. So this causes symptoms similar to your right heart failure. What are the symptoms? There can be pulmonary congestion. Which leads to dyspnea, and there can be anasarca as well. Fine. Now let us look into the etiology of restrictive cardiomyopathies. So most importantly, we have the infiltrative etiologies. So the infiltration can happen between two myocytes, right? So the infiltration can happen between two myocytes. So infiltration can be here, or the infiltration can happen within the myocytes itself. So this is your other type of infiltration. So what are the causes for the infiltrations which happen between two myocytes? We have the amyloidosis and we have certain inherited metabolic defects. So especially amyloidosis is one disorder where there is infiltration of the amyloid fibrils between two myocytes. So we know that there are three types of amyloidosis. We have the light chain amyloidosis, which is associated with which hematological disorder? It's associated with multiple myeloma. Then we have the familial amyloidosis, which is associated with transthyretin mutation. Abnormal protein called transthyretin gets accumulated and it goes and infiltrates between the two myocytes. Then we have a senile type of amyloidosis. Fine. Then within the myocytes, it occurs due to storage disorders. What are the storage disorders? We have learned hemochromatosis, Fabry's disease, glycogen storage disorders. So all of them can cause a type of restrictive cardiomyopathy. But we had also learned that hemochromatosis can cause dilated cardiomyopathy as well. Okay. Then post-fibrosis because of radiation, and a very important connective tissue disorder which causes restrictive cardiomyopathy is your scleroderma. Then endomyocardial involvement. Sometimes they can be endocardial as well as myocardial involvement which causes a type of restrictive cardiomyopathy. This is seen in tropical endomyocardial fibrosis and in Loeffler's endocarditis, which is again a type of hypereosinophilic syndrome. Okay. Then it can be associated with carcinoid syndrome, and drugs which cause fibrosis like serotonin and ergotamine are also associated with endomyocardial fibrosis. Now, Certain other causes of restrictive cardiomyopathy includes sarcoidosis, but the most common cardiac presentation of sarcoidosis is actually a DCM. Okay, so this is about the etiology of restrictive cardiomyopathy. Let us look at the clinical features. So the first clinical feature. So what happens in restrictive cardiomyopathy? What happens in restrictive cardiomyopathy is that there is stiffening of the ventricles. Because of this infiltration, there is stiffening of the ventricles. So over the course of time, what happens to the pressure? The pressure in the atria becomes increased. The pressure in the atria increases. What happens to the atria then? They become massively dilated. So you can find massive dilatation of the atria, which is also called as biatrial enlargement, and on the echo this is also called as what? This is also called as owl's eye appearance. Owl's eye appearance. Okay. So what happens if the atria stretch beyond a particular capacity? There will be backward pressure, right? So there is increased left atrial pressure, which causes increased pulmonary capillary wedge pressure. There will be transudation of the fluid. And finally this results in pulmonary edema. And so what is the first symptom that they can present with? They can present with dyspnea. Over the course of time, what happens is that as the RV fails further, it can result in an elevated JVP. It can result in a hepatomegaly because of what? It is a type of congestive hepatomegaly, right? So it can result in congestive hepatomegaly, and you can also have pedal edema and anasarca. Pedal edema, abdominal distension and anasarca. So you can have pedal edema, abdominal distension and anasarca. So the symptoms, in toto, the symptoms with which the restrictive cardiomyopathy presents is very similar to a right heart failure. Okay. Now let us look at the investigations that can be used in the diagnosis of restrictive cardiomyopathies. So we will look at the classical example, which is nothing but your amyloidosis. Okay, the classical example, which is your amyloidosis. So what do you see on the ECG? You see that there are deep Q waves and poor R wave progression. Deep Q waves and poor R wave progression, which is called as the pseudo-infarct pattern. Also, you see low voltage complexes. With the pseudo-infarct pattern. This is classical of your ECG of amyloid. Okay, fine. Now ECG is okay. Let us go to the echo finding. The classical echo finding that you see is, can you see that this is a speckled or a sparkling appearance? This is your speckled or sparkling appearance. So a speckled or sparkling appearance on the echo is suggestive of amyloidosis. Alright. So a speckled or a sparkling appearance is suggestive of amyloidosis. Now let us look at the cardiac MRI findings. Cardiac MRI, we have already learned that there can be a global involvement. So a global involvement of the myocardium is seen in amyloid. Okay. So global involvement of the myocardium is seen in amyloid. So what is the treatment of restrictive cardiomyopathy? So when it comes to the treatment of restrictive cardiomyopathy, you have to treat the symptoms of right heart failure. So many times it will be associated with pulmonary hypertension, because the left atrial pressure causes a backward pressure to increase pulmonary capillary wedge pressure, and it can be associated with pulmonary hypertension. So you give drugs which basically cause symptomatic improvement or pulmonary hypertension, then you can give a small dose of diuretic to reduce the edema. Small dose of diuretics to reduce the edema. Beyond this symptomatic treatment, we do not have much to offer for the treatment of this restrictive cardiomyopathy. But if you find the underlying cause and you treat the underlying cause, then definitely you can treat the restrictive cardiomyopathy. Right? So that is about restrictive cardiomyopathy. We have a special drug which is used in the management of ATTR amyloidosis, which is called as tafamidis. Okay, so that is about the management of restrictive cardiomyopathy. Fine. So what all have we learned? We have learned about the etiology. We have learned about the various clinical features. We have learned about how to investigate and the treatment of restrictive cardiomyopathy. Okay. Now let's move on to the next type of cardiomyopathy, which is your hypertrophic cardiomyopathy. As the name suggests, there is an asymmetrical hypertrophy of the myocardium. So this is what we call as the hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy is the most common cause of sudden cardiac death. So a sudden cardiac death patient. So if you go through the group of patients who have had a sudden cardiac death, the most common cause has been a hypertrophic cardiomyopathy. Okay. So this is the most common genetic cardiovascular disease as well. And the most common gene that is involved is your MYH7 gene. The most common gene that is involved is your MYH7 gene, which is your myosin heavy chain gene. Okay. So this is about the most commons for hypertrophic cardiomyopathy. Now, there is a variant of hypertrophic cardiomyopathy that you can see here. This is called as the Yamaguchi variant. So what you see in the Yamaguchi variant? So if you see this echo, does it resemble the ace of spades? So if you have all played cards, you will know that there is an ace of your spades. So this ace of spades appearance, can you appreciate on this echo? So this is what is called as your Yamaguchi variant of hypertrophic cardiomyopathy, and this is what we call also as your apical HCM. So normal HCM usually, or the most common type of HCM, has a septal hypertrophy. It has an asymmetrical septal hypertrophy. In this Yamaguchi variant, there is only apical hypertrophy. And the characteristic ECG finding that you see is diffuse P-wave inversion. Okay, so this is about your Yamaguchi variant of HCM. Fine. Now let us look at the pathophysiology of HCM. So every HCM does not cause symptoms. Unless the hypertrophy is that much that it causes obstruction, you will not have much of symptoms. So can you notice here in this line diagram, this is the LA, this is your mitral valve, this is your aorta. So you have an asymmetrical septal hypertrophy due to genetic causes. There is an asymmetrical septal hypertrophy. So the first part is that whenever there is a hypertrophy, the LV cavity size decreases. So what happens to the pressure in the LV? The pressure in the LV increases, and this is transmitted to the LA, and the LA becomes enlarged as a compensation. The LA becomes enlarged as a compensation. Also, don't you feel that this asymmetrical septal hypertrophy causes a decrease in the LV cavity size, and also there is an obstruction to the flow of blood from the LV to the aorta? There is an obstruction to the flow of blood from the LV to the aorta. Where is the level of obstruction? Where is the level of obstruction? The level of obstruction is below the aortic valve. It is below the aortic valve. That is the reason why the HOCM, or the hypertrophic obstructive cardiomyopathy, is also called as idiopathic subaortic stenosis. Idiopathic subaortic stenosis. Fine. So what happens when the cardiac output decreases? The cardiac output decreases because of the obstruction. So this causes a decrease in the cardiac output, and very frequently this can cause a syncope. So very often the clinical case scenario which is used to describe the hypertrophic obstructive cardiomyopathy patient is history of exertional syncope and family history of sudden cardiac death. You should think of HOCM. Fine. Now, the hypertrophy causes increased LA size because of the pressure overload. Now, as the LA increases, what have we learned? We have learned that the LA pressure increases, there will be backward pressure. So, this causes an increase in pulmonary capillary wedge pressure, and this can cause pulmonary hypertension as well. Fine, so they can present with dyspnea as well. Also, this LA enlargement can predispose to which arrhythmia? It can predispose to atrial fibrillation. It can predispose to atrial fibrillation. Fine. So, they have symptoms of decreased forward flow resulting in syncope, and they can have arrhythmias as well, which is your atrial fibrillation. Now, let us look at the second point. Whenever there is a high velocity jet across the aorta. So, whenever there is a high velocity jet across the aorta, if you go back and go through the lectures on the basic mechanisms of pulse, you would have learned what is the Venturi effect. So, I have taught you what is the Venturi effect. Now, let us just recapitulate what is the Venturi effect. So, whenever there is a fluid which is flowing through a tube and it encounters a narrowing, when it encounters a narrowing, what happens to the velocity here? The velocity increases, and what happens to the pressure in the surrounding area? The pressure decreases. So, whenever there is a fluid which is encountering a narrowing, the velocity of the jet increases and the pressure in the surrounding area decreases. So, this is exactly what happens here, correct? So, the blood goes to the aorta. As the blood goes to the aorta, what happens? The velocity is going to increase because of the narrowing. What happens to the pressure here? So, what happens to the pressure in the surrounding area? The pressure is going to decrease. So, the pressure is going to decrease. Now, if the pressure is going to decrease, don't you feel that a vacuum-like situation is created? So, because of this decreased pressure, what gets pulled here? What gets pulled here? The mitral valve. The mitral valve gets sucked in. Mitral valve gets sucked in. In which phase? The blood is going out to the aorta in which phase? During systole. Right? So, this is what we call as the systolic anterior motion of the mitral valve. So, this is what we call as the systolic anterior motion of the mitral valve. And what happens when the mitral valve gets sucked in? This mitral valve goes and obstructs here again. So, this mitral valve goes and obstructs here again. It obstructs the LVOT. This causes obstruction of the LVOT, obstruction of the left ventricular outflow tract. And this is what we call as the dynamic obstruction. This is what we call as the dynamic obstruction in HOCM. This is what we call as the dynamic obstruction in HOCM. Why is it dynamic? Because this happens only during systole. Okay. So, let us just understand this concept again. So, whenever there is a high velocity jet across the aorta because of the asymmetrical septal hypertrophy, let us consider that this is the aorta, this is the LV. So, the velocity increases. As the velocity increases, the pressure in the surrounding area decreases. Now, what valve is here? It is the mitral valve. The mitral valve gets pushed, or the mitral valve gets sucked in, and it causes obstruction of the left ventricular outflow tract. So, this is what we call as the systolic anterior movement of the mitral valve and the dynamic obstruction which is seen in HOCM. Fine. So, this is about your pathophysiology and the hemodynamics of HOCM. Okay, so we have understood how hypertrophy causes various symptoms and what is this dynamic obstruction which is seen in HOCM. Alright, so clear till here. Now let us move on to the next part. So, clinical features. So, what are the clinical features of HOCM? There will be dyspnea. There will be dyspnea. So, why is there dyspnea? We have already seen because of pulmonary congestion you can have dyspnea. You will have palpitations because of atrial fibrillation and you have syncope because of the obstruction and especially during exertion. So, we always tell HOCM patients to avoid athletic activities because you can have a syncope which is often fatal and there is also an increased risk of sudden cardiac death. This is the pathological specimen. As you can see here that this is the LV cavity, this is the LV cavity, this is your mitral valve and can you see that there is an asymmetrical septal hypertrophy and the LV cavity becomes banana shaped. So you can see that the interventricular septum is so much hypertrophied that the LV cavity size itself is decreased. And what do you find under the histological sample? In the histology, you see a helter-skelter pattern of cardiac myocyte arrangement. You see a helter-skelter pattern of cardiac myocyte arrangement. Okay. This is about the pathophysiology and the pathology of HOCM. Fine. Now, let us move ahead. Let us look at the clinical signs which are seen. So, what happens to the pulse in HOCM? What type of pulse do you find? You find the pulsus bisperiens. You find the pulsus bisperiens, which means that there are two peaks in systole. So, there are two peaks in systole. So, which type of pulse do you find in HOCM? You find the pulsus bisperiens. Okay. So, what is the mechanism of this pulsus bisperiens? You can go back and see the chapter on pulse as well. Let us briefly explain the pulsus bisperiens here. So, there are two peaks in systole. So, first peak is because of the flow across the obstruction. So, there is a positive pressure generated and there is a peak. The second peak is because of your systolic anterior motion of the mitral leaflet and the dynamic obstruction. Right? So, to overcome this systolic anterior movement, the heart contracts more and you have your second peak which results in this pulsus bisperiens. Alright. Now, second, the BP. The BP is usually normal. In later stages in syncope, the blood pressure can fall. The JVP is usually normal as well. Now, what happens to the apex? The apex can be a double or a triple apical impulse. In the apex, you can have a double or a triple apical impulse. Okay, now let us look at the auscultatory findings. The S1 is usually normal. What happens to the S2? So, we know that there is a huge pressure gradient across the aortic valve. Correct? So, there is a huge pressure gradient across the aortic valve. So, what happens to the hangout interval? What happens to the hangout interval? So, we have learned in the chapter on heart sounds what is this hangout interval. So, hangout interval basically refers to the time which is basically present between the pressure crossover and the valve crossover. So, if you see here, whenever you see in the Rigger's diagram, let us say that this is the LV curve and this is the LA curve. The point at which the pressure of the LV crosses the LA pressure or the LV pressure becomes higher than the LA pressure. The point at which the LV pressure becomes higher than the LA pressure is what we call as the crossover. Right? So, the point at which the LV pressure becomes higher than the LA pressure is your pressure crossover. Followed by which there will be closure of the valves. Closure of which valve? Closure of aortic valves. So the time between this pressure crossover and the actual valve closure is what we call as the hangout interval. So when the pressure gradient is high, where is the pressure gradient high here? In HOCM, the pressure gradient across the aortic valve is high. So the hangout interval across the aortic valve is more, and the hangout interval across the pulmonary valve will be decreased. So if the hangout interval is more, the A2 occurs late and the P2 occurs early. So what happens? The normal split is A2, P2. Now the A2 is occurring late, so it becomes a reverse split. Okay, so that's about your second heart sound. Will you have an S3? Yes, you can have an S3 because of the flow of blood from the atrium to the ventricle. The ventricle becomes non-compliant and hypertrophied, and you will definitely have an S4 because of the non-compliant and hypertrophied ventricle. Alright, fine. Let us look at the murmurs which are seen in HOCM. Now let us look at the murmurs of HOCM. So the first murmur that we see is that we hear a pansystolic murmur. Pansystolic murmur in the mitral area, because the systolic anterior movement of the mitral leaflet can be associated with some amount of mitral regurgitation. So there is a PSM in the mitral area, and the obstruction results in the ESM or an ejection systolic murmur in the parasternal area. Okay, so if you hear a PSM in the mitral area and an ESM in the parasternal area, this is suggestive of HOCM. Okay, now let us look at the dynamic auscultation. Now, it's very simple. You just have to remember one single point. The murmur depends upon the size of the LV cavity. So, if the LV cavity size increases, then the obstruction decreases. And the murmur decreases. If the LV cavity size decreases, the obstruction increases and the murmur increases. This is the only basic thing that you have to remember. So, when does the LV cavity size increase? If you increase the preload, right? So, if you increase the preload, you give them fluids, or you do a squatting, right? You give the patient fluids or you do squatting, the preload increases, the LV cavity size increases. If the LV cavity size increases, what happens? The obstruction is relieved because the hypertrophy also comes down and the systolic anterior movement also comes down. That is the reason why increasing the preload will decrease the murmur. Okay. Now, how does the LV cavity size decrease? If you decrease the preload, you give the patient diuretics. What about the afterload? How do you increase the afterload? If you increase the afterload, what happens? The LV cavity is again going to increase in size. So, what happens to the murmur? The murmur will decrease. So, you increase the afterload by hand grip. Then the murmur is also going to decrease. Okay, so this is about the very basic principles of dynamic auscultation in HOCM. Now let us look at the investigations. What do you see on the ECG? You see evidence of left ventricular hypertrophy because of the obstruction there is a pressure overload. Apart from that, you find this Q waves which is called as the dagger-like Q waves in the septal and lateral leads. The dagger-like Q waves is a characteristic feature of HOCM. Okay, is a characteristic feature of HOCM. In the echo, you will find your hypertrophy, and you can also appreciate your systolic anterior movement of the mitral. Fine. We come to the treatment. Let us look at this flow chart for the treatment of HOCM. Fine. So, if the patient is at risk for sudden cardiac death, right? So, you consider an ICD if the patient is at risk for sudden cardiac death. Now, how do you evaluate for that? If there is a family history of sudden cardiac death, if there has been a history of cardiac arrest in the patient prior, history of cardiac arrest in the patient itself prior. So this means that the patient is at a definite risk of sudden cardiac death and you consider placing an ICD. So what is an ICD? ICD basically refers to implantable cardioverter defibrillator. So this is an implantable defibrillator which is placed in a subcutaneous fashion. So what happens is that whenever there is an arrhythmia, it detects the arrhythmia and gives a shock and it terminates the arrhythmia. So in those patients where there is a family history of sudden cardiac death or history of cardiac arrest in the patient himself prior, then you will have to put in an ICD. Okay. Now, then you see if the patient is symptomatic, right? If the patient is symptomatic and there is evidence of fluid retention, then you can use diuretics, right? But you have to use diuretics with caution because we have already seen that if you decrease the preload with diuretics, the obstruction can increase. So you have to use diuretics with caution, particularly when the gradient is high. Okay. If they are not in fluid overload, the first drug that you will use is a beta blocker, followed by which you can use calcium channel blocker if there are persistent symptoms. So if there are persistent symptoms, you use disopyramide. Now if the symptoms are refractory despite using beta blockers, calcium channel blockers and disopyramide, then you can use surgical procedures including septal ablation, which can be surgical or alcohol septal ablation. Right? So a new drug which is being used in the management of HOCM is your allosteric modifier of myosin, which is called as mavacamten. So the newer drug which is used in the management of HCM is an allosteric modifier of myosin, which is called as mavacamten. Fine. So that is about the management of HCM. Okay. So this brings us to the end of this topic and discussion on cardiomyopathies. I hope you've understood this topic well. So see you next time. Thank you.